to the Make a Mental Note podcast, where mental health professionals share information and perspectives that illuminate, educate, and is worthy of a mental note. And now your host, Chris Quarto.
Hi everyone, this is Chris Quarto. Welcome again to the Make a Mental Note podcast. Today's mental health tip has to do with dealing with urges and cravings. I thought that this would be a particularly good little technique given that today's podcast episode deals with addictions counseling. There's a neat little technique on the Smart Recovery website that was posted by Randy Lindell several years ago that shows how you can deal with urges and cravings. It uses this acronym DEADS, D-E-A-D-S, and each letter stands for something. D stands for delay. If you have cravings and urges, understand that these will go away, and if you can delay just for a minute or two and not do anything, not act on those urges or cravings, but just wait at least 2 minutes, and then if they still don't go away, wait for another 2 minutes, and then if they still don't go away, wait for another 2 minutes. So divide that delay into little segments like this because smaller segments are easier to deal with, similar to the idea of the 1 day at a time of Alcoholics Anonymous. E stands for escape. Just get away from the situation. Oftentimes we have urges and cravings because we're in a situation where something might trigger these feelings. And so just, and maybe not, but just getting out of that situation for temporarily will get your mind onto something else, or at least will help you reduce those urges and cravings. Acceptance is putting your urges and cravings into perspective by just understanding that these are normal. They'll pass, but they're normal to have. It's not going to kill you, but it's uncomfortable. But accepting that this is something that I have to deal with my condition is part of the process. D is disputing. This is a cognitive behavioral approach where you argue with the thoughts such as, I've just got to have a drink. I've just got to use. I can't handle this anymore. With thoughts like, no, you don't have to. Just let it pass for a few minutes and this will go away. So arguing with the thoughts and disputing them, irrational thoughts, which is a very cognitive behavioral approach, that's oftentimes helpful. And then substituting that thought or activity with something that's more beneficial, more fun. Take a walk, any form of exercise. Try to find something that will get your mind off from the urges and the cravings, at least for a brief period of time. So that's my mental health tip for the day. Okay, today's podcast episode is with Stacy Speedlin, and here is Stacy. Hi everyone, this is Chris Quarto, and welcome again to the Make a Mental Note podcast. Thanks for joining me. Well, today we are joined by Dr. Stacy Speedlin, who is an adjunct professor at the University of Texas at San Antonio, and she's also a therapist. She is a licensed professional counselor and a licensed addictions counselor. And Stacy, thanks for joining us on the podcast interview today.
Thank you for having me, Chris.
Well, Stacy, if you wouldn't mind, tell the mental note-taking audience a little bit about who you are and what you do for a living.
Okay. Well, as you mentioned, I do have a PhD. My name is Dr. Stacy Speedlin. My PhD is in counselor education and supervision. Mm-hmm. I'm also a licensed professional counselor, and here in the state of Texas, I'm a licensed chemical dependency counselor. I have 3 jobs. Currently, I'm working full-time with the Mental Health Authority of Bexar County, where we provide mental health and addiction services to adults with severe disorders.
Okay.
I also work in an intensive outpatient clinic for clients with substance use disorders. And just like you mentioned, I'm also an adjunct professor at UTSA. I teach the crisis course and the addiction course to master's level students.
Oh, boy. So you're one busy person, aren't you?
I like to stay busy, yes.
Oh, okay. That's fantastic. Well, I always like to talk to my guest about what got them interested in the field of counseling, and the reasons really vary. But what got you interested in this field, Stacy?
Well, you're asking the tough question first. And truthfully, when people ask me that question, I'm often confronted with how transparent to be. On the surface level, I got into the counseling profession because I always knew I wanted to help people. My mother had actually raised me. She talked a lot about having a servant's heart. She used to say things like, to whom much is given, much is expected. And I was planning on becoming a medical doctor. That is, until I saw blood and guts. I just knew at that point it was not for me. So I chose counseling. And at that time, I happened to have a friend who was an LPC. She had tattoos. She was a certified dance therapist. I was really inspired by her.
Wow. Okay. That's cool. Yeah, I can remember, you said that you had that servant's heart. I can remember my mother was a school counselor. And, growing up with a person like that, I think it has a big influence. I think there are personality traits that go along with it too. But I can remember when I was in third grade, we had to write a paper for our teacher about what do you want to be when you grow up? And I wrote this paper on, I want to be a psychiatrist, not really knowing what a psychiatrist was. As far as I knew, it was just the same thing as a counselor, or just somebody who wanted to help and be helpful. So sounds like you had that same sort of idea as you were going along in life too, just wanting to be a helper.
I did. It was really modeled for me in my home. My mother was a judge for many years, and she's an attorney currently and still working, which, I think by reputation, they're not often viewed as being helpers. But she really was. She had a real value on helping the community. She took her job very seriously. She's actually created some nonprofits here in San Antonio to help individuals who can't afford legal services.
Wow.
And that's always been her avenue, is that we need to help others. She never feels like she does enough for the community.
That's fantastic.
It impacted me.
Oh, that's fantastic. I think so often that the underserved get and the marginalized, they get overlooked, and it's really nice to hear about those types of things, and we should probably be doing a lot more of that, actually. Now, you had said that you had worked with people with some severe mental disorders and also with addictions. Say a little bit more about that, if you would, Stacy.
Sure. Well, where I currently work, in terms of working at the Mental Health Authority, and where I work in two clinics that are very, very, very much on different sides of the spectrum. Working for the Mental Health Authority of Bexar County, I often see people who are impacted by addiction and mental health in ways that is affecting them in every area of their life. It's not uncommon for me to work with individuals who are homeless, to work with individuals who are engaging in prostitution. CPS is involved in their case. When they come to us, they've been affected on all areas, and it's a lot of work. Without our services, I often feel that they would be our most vulnerable citizens at risk of being taken advantage of, being injured, being hurt. Oftentimes there's co-occurring issues. The mental health impacts the ability to seek addiction counseling. It persists the use of drugs and alcohol to cope with symptoms. There's so much going on for them. And on the other
go ahead. No, go ahead.
On the other hand, the other clinic that I work for is a private sector clinic where we take insurance, where most of our clientele is gainfully employed, has insurance, oftentimes is still married with 2 cars in the garage.
Okay. All right. Well, let's talk a little bit more about addictions. That's what I really wanted to focus on in this particular episode. And there's so much to know about this, and I'm curious just to get your take on just kind of going back to how does this all start with a person? I'm sure that there are different reasons, but how is it or why is it that people become addicted to substances? And we could also talk about process addictions too, but I'm kind of interested in substance addiction at this point.
Sure. Well, as you mentioned, it's not a simple response.
Yeah.
The fact of the matter is people become addicted to substances for various reasons, many reasons. What are the commonalities that I see? Oftentimes when people come to me, and this is something that is not uncommon knowledge by any stretch, but there's a lot of pain present. Many years into this field, I came to understand how pain is very personal. What someone may define as a pivotal experience or painful, it may not be viewed that way to others.
Okay.
But regardless, it has impacted the individual. When people are under the influence of substances, everything that they have experienced, any hurt, anything traumatic in their life, it has become compartmentalized because the addiction does not permit them to feel.
Okay.
So when they come to me, there is a great deal of pain. I also hear from clients that they do not feel connected. A description I hear very often is that they feel they're on the outside of their life looking in. They're staring at a life that they're completely disconnected from, and they want to be connected. Chris, addiction is a very stigmatized disorder. And oftentimes people are blamed for the illness, as if they've done it to themselves, per se.
And I guess that's what I wanted to talk to you a little bit more about, because there's the disease concept, and some people may not be familiar with that concept, and maybe you can talk a little bit about that, Stacy.
About which particular concept? I'm sorry.
About the disease concept as it relates to these disorders.
Well, it's becoming much more widely accepted that addiction is in fact an illness or a disease, if you will. For me, I more commonly describe it as an illness.
All right.
Having addiction as a disease would be kind of similar to describing a heart attack as heart disease. We know that there is no disease per se that infects the heart that causes a heart attack. The same thing can be said for addiction. Addiction is not a disease that is, quote, contracted or developed, but rather it's a progressive illness with progressive symptoms.
All right.
And why it's important to acknowledge it as an illness is because in the past, people have often viewed addiction as more of a moral issue or a choice versus a person who themselves are powerless. If it were as simple as making a decision to stop drinking and using, my clients wouldn't need me. They would be at home making a decision not to drink or use. But addiction has such I want to say addictive factors, but the fact of the matter is it becomes progressive. The obsession of the mind and the compulsion of the body leads them back to the substance regardless of the consequences. And in that respect, we can say it's an illness because despite the need or the wish to stop drinking and using, people will continue to do so, even at times against their own desires, even against their own wishes. They will start drinking and using again and have to pay consequences that even they themselves don't want to pay.
How many times have you had discussions with clients where they've said, I'm going to stop drinking, and perhaps they have for maybe a week, and then they've gone back to it. And then they said, I screwed up, but this week I'm going to stop. And maybe they do, and then how often does that happen?
Quite frequently. And it happens because just similar to the family members or the community or the loved ones surrounding them, people don't understand what they're up against when they have an addiction. They think that just the fact that they are clean and sober today, that's enough to keep them that way. What they don't understand is that without some type of intervention, without, for lack of a better term, going under the hood to kind of understand what's going on that's causing them to continuously go back to the illness, without even describing it as an illness and defining it in such ways as you and I are talking about now, individuals will continue on that cycle, in my experience. They'll continue to go back believing that they're okay, believing that they're out of the woods. Because they've made a decision, because it was painful, whatever consequences they recently endured, because they've been threatened by family. They think that's enough.
Yeah.
And it's not.
Yeah. So, so there's been this belief that people in the past, I guess, what you were talking about with that, I guess that moral model is that people have control over themselves and they should be able to stop drinking if only they would exert enough willpower, right? That's the old thinking about addiction, and it's just not that easy from what I'm hearing you say.
Correct. Probably the most common experience that I can describe, and I often describe this to master's students that I work with. And by the way, I'm teaching the addiction class at present, and the first thing I ask them to do is to give one thing up that they really liked throughout the semester, and I ask them to journal on how well they did.
Ooh.
Most of my class will relapse.
But what a great way to get them to identify with people with addictions, huh?
It's very similar to going through a breakup. You know, I think we all in life have gone through the breakup that we didn't want to happen. The person that we were dead set on being in a relationship with that no longer wants us. And it's painful. And if you're anything like me, you've got supportive friends around you that say they were no good for you, you're so much better off without them, you never liked them, you feel good, you feel uplifted, you feel like everything is going well. And then Friday night happens.
Right.
And you're at home, and they're out with their significant others, and all of a sudden, your mind begins to play tricks on you, and what it tells you is you've left your favorite socks at their house, and those are your favorites, and you have to have them, and so you find any trivial excuse for going over there to retrieve those socks, and then the pain sets in again. Your friends come by. Why did you call them? You said that you didn't want to talk to them anymore. You said that this was bad. This was not a healthy relationship for you. We've all been there. But sometime during that, quote, breakup is the grief. And coupled with that inaudible voice that tells us, if I could just get them on the phone, if they could just tell me that they love me, if I could just hear their voice one more time, this pain would stop. When we're working with people with addiction, often what we're doing is we are helping them through the breakup. The breakup of a very entrenched relationship that they have been in for sometimes decades.
Yeah. And that's a fantastic analogy, Stacy. And I think that it really shows people how powerful a substance can be, because it's a person's best friend or girlfriend or boyfriend or whatever, but it's their best friend. And you're telling me that I have to give this up and that I'll never be able to see my friend again. And the fact that what you had said about grieving, I think that that's plays a huge role, and you can understand why people would have such difficulty giving this up. It's a major life change, isn't it?
It is. Even though cognitively we all know that relationship is no good, there's a part of us that is just more comfortable in the status quo because it's familiar. Because what if I let this go and I never find anything else? We all have reasons for staying in relationships that are unhealthy. And addiction is just that. It's an unhealthy relationship. Despite the consequences, despite the pain of the status quo, we find that comfort level in it. We find ways to rationalize and accept what's going on, even though it's painful, even though it's costing us things things that we don't want to pay, prices we don't want to pay. It is still familiar, it's comfortable, and at some point I think we all play that mind trick on ourselves, which is, this is the best I can hope for.
Yeah.
This is just the way things are. It won't be any different. And maybe I don't deserve anything different.
Right. Yeah. Yeah, that's a lot of questioning that goes on there. Now, what's your opinion about how people are referred to with addictions? Because sometimes, if the old AA thing, recovering alcoholics, referring to a person as an alcoholic as opposed to a person with a problem with alcohol or something, along those lines. What's your kind of take on that, Stacy?
In terms of what Alcoholics Anonymous does, I do understand why they use that terminology. Mm-hmm. There's a lot of talk in the field about how rejecting and shaming that language is, and the idea that, well, if you have to say you're an alcoholic every day, isn't that kind of self-fulfilling prophecy? In reality, that's my understanding, based on people I've talked with, is that's not why AA does that. And it's important that we have this dialogue about this, because this seems to be a perpetuating conversation. Mm-hmm. AA does that because when people come to AA meetings, it's important that they announce themselves as being an alcoholic, because that qualifies them for membership so that they can conversate and talk in the meetings.
Sure.
If you are not an alcoholic, they ask that you can attend, but you cannot share. Mm-hmm. So when someone says, my name is so-and-so and I'm an alcoholic, that is for the purpose of announcing your membership. Mm-hmm. And they'll allow you to proceed and share, versus if you were a family member going in there, or a nursing or counseling student that just was observing for the purpose of your class.
Right.
That's how they tease out the two. Now, in terms of our profession, we do want to use person-centered language, mm-hmm. because it's important that we don't, as counselors or psychologists, fall into the trap of identifying a person based on their illness.
Right.
Your terminology was correct when you said a person with a substance use disorder versus an alcoholic or an addict. Mm-hmm. That's really addressing somebody based on what they have, and it's also assuming that there's nothing more to them.
Right. It's marginalizing them, essentially, is what's happening there. And I think that, when you think about, what these people are oftentimes dealing with anyway, whether it's shame or embarrassment, it's just kind of adding more fuel to the fire, I guess. I wonder, Stacy, when you work with clients, do you find that there are common themes or stories that seem to underlie their problems, people who are having difficulties with alcohol or drugs?
There are some common themes. Now, the stories are very, very different.
Sure.
I've met people from an entire spectrum. In one clinic, I work with someone who has a $600,000 house in Plano, Texas, and had a trust fund all their life.
Wow.
At the other clinic, I work with individuals who have been so brutally abused by family members and relatives and people that should have kept them safe. They've lived in poverty all their life. They've been oppressed as a person of color, mm-hmm. and have lived most of their adult life on welfare and in shelters. Uh-huh. So the stories are vast and different, but the themes, I think, they're similar. And you mentioned one, and that is a great deal of shame is associated with addiction, whether it happens before the addiction or as the result of. There's a lot of shame involved, low self-esteem, mm-hmm. things like depression, free-floating anxiety. I often ask that in my intake, do you ever feel depressed and nothing has caused it? It just comes on and you don't know when it's going to stop. And they'll say yes. Uh-huh. Free-floating anxiety, the inability to relax, the inability to sit still. I have clients describe that they want to unzip their skin and jump out of it mm-hmm. with no antecedent, no cause for that. It just kind of seems to come on. And so using regulates that.
Mm-hmm. Sure. Oh, yeah. So really, when you look at these substances, it really, they serve a positive function in that it helps deal with some of these feelings that they're having, I suppose. And I wanted to ask you just about shame, because that was the first thing that you mentioned there. Where does that shame come from, Stacy? Could you give an example of why a person who's using might feel ashamed?
Well, for one main reason, our society really does not look at addiction as an illness. It is still against the law. There's a lot of criminology associated with addiction. We often see clients who fall into criminal justice systems, child protective services. There's just so much involvement that does not come from a person-centered perspective, rather comes from a very punitive, you've done this to yourself, you're a bad mother, you're incapable, you cannot run your life, we must run it for you. A lot of lack of autonomy there, and of course that perpetuates shame. There is some issues with institutional re-traumatization, I believe, that when we are putting them in certain systems that do not come from a person-centered approach. I've seen people in the profession who have perpetuated more shame and re-traumatization by talking to individuals with an addiction as if they are 11 years old.
Wow.
Coming from this place of, look at you, you've burned your life to the ground, and now you're here. And if you're not serious about this, if you're not ready, if you're not willing, if you're not doing what other people are doing, then come back to us when you're serious.
Wow.
That's not a very good approach.
Yeah. And, and I wonder if that's kind of like I guess like an old school approach, and hopefully we've learned more as therapists about the proper way to treat people with addictions, but perhaps not. I mean, maybe there are still those types of therapists out there that are using that shaming or guilt-ridden, type of approach to deal with people. And for me, it kind of makes me wonder why would you ever treat a client like that? And from what you're saying, and I've heard you say this a few times, that person-centered approach. And why don't you say a little bit more about that, Stacy? Because I think some of our listeners may be familiar with that, but what do you mean by that?
There are much more autonomous and what's the word I want to use? There are theories that we are currently using, such as motivational interviewing, for CHAPSA, stages of change. I think that really fosters better connections and mutuality in terms of the therapeutic relationship that counselors are having with clients. You're correct. The confrontational, direct, finger-pointing style of counseling is an old form of addiction counseling. Historically, when addiction counseling first started to formulate, it was actually individuals who were in recovery themselves who became our first addiction counselors. As the counseling profession started recognizing that this was more of a specialty and did not necessarily, well, let's just say that our traditional theories didn't really encompass the ability to meet the needs of the clients who had addiction. They created it as a specialty. We had non-licensed lay persons who originally took these roles, and I believe that they attempted to do kind of what they do in 12-step recovery at times, where it's a lot more black and white, and I think in 12-step recovery it needs to be. But for clients that look at a counselor and have an expectation that we're going to treat them a certain way, that develops a lot of resistance with the black and white type of finger-pointing, confrontational. So throughout the years, we have evolved as a profession in a good way. Now, are people still in our field that may have that old type of approach? I believe yes. I would also go a step further to say that even though we are teaching much more person-centered approaches and individuals are getting better education on working with addiction, I also need to recognize how frustrating it is to work with addiction, and I understand that, particularly with newer people in our field. And I want to normalize that experience because it is hard to work with someone. I remember as an intern, one of my first clients was using IV heroin while pregnant, and she used until she miscarried. And I remember just having a very hard time with that internally. Not necessarily from a judgmental perspective, although I have to acknowledge that some of that was present for me, being so new and, wide-eyed and thinking I was going to save the world.
Yeah.
But there was a big part of me that wrestled with, how much am I at fault for this? Oh. Could I have said something? Could I have done something to made her not do this? And I think at times I caught myself being more confrontational than I needed to be. Just coming from a human place of, what do I do? This person is struggling, they're hurting themselves, they're hurting their unborn child, what do I do? And times I caught myself being like that family member saying, well, how is this going to help you get your goals? And do you think, this is that is helpful to your child? Looking back, I can see it much more from a hindsight perspective, but at the time, the feelings associated with it, the powerlessness.
Oh, sure.
Made it very hard.
Yeah.
And I think.
Go ahead.
Go ahead.
Yeah, I was just thinking of a family member who has no control over what's happening with another family member who's using. And it's the same type of deal, isn't it? It's just that feeling of powerlessness. There's nothing that you feel like you can do. And there may be thinking that, well, why didn't you just stop using? If you didn't use this, you wouldn't have all these problems. But like we were talking about before, it's not that easy. And the person who's using doesn't feel like they can really control what they're doing. And the family member doesn't feel like they have control. So it's almost like a parallel process that's going on there.
Correct. Yes.
Well,
and for that reason, I think it's important that we also incorporate family counseling within the context of addiction counseling.
Yeah, that makes total sense. Yeah. Well, now we have these people. They're coming in to see you. They need your help, and I think I heard you say that in some instances there may be some resistance there. I guess some people are coming in for help. They really want help, but there's going to be some going back and forth like we talked about. Other people may be mandated and not really want to be there to begin with. So what do you do with those people, Stacy? They're ordered by the court, or a family member is threatening them, saying, if you don't get into treatment, I'm going to divorce you, or whatever. How do you deal with those people who are there but don't really want to be there to deal with their addiction?
Sure. Regardless of whether they're mandated or motivated by other external factors, it's important, I think, for us to acknowledge that ambivalence is a normal part of the process. Just like ambivalence we would have for anything else. In terms of stages of change, nobody really comes in at a level 10. I'm ready to change my life. I want to start exercising. I'm never going to eat sugar again. There is some payoff, right, to both sides. There's payoff to not eating sugar. There's payoff to eating sugar. And so what we do with any client, regardless of why they come in, is we want to tease out some of that ambivalence. I use a lot of scaling with them. I had a client recently who came to me that just really, frankly, like most of my clients, cannot visualize a life without substances. Just doesn't have a construct for it, doesn't know what that would look like. All they know is that every time they've tried to come off of the drugs, they feel terrible.
Right.
They feel depressed, free-floating anxiety. They can't get along with their family. Nobody trusts them. They're still on probation, regardless of being sober, and nobody's treating them like they've made any changes. So it's a long road, and that's the only construct they have to sobriety or abstinence. So he had vocalized to me one of his big fears, and I've heard this a lot, is if I stop using, I won't be able to sleep.
Oh.
And that's a terrifying thing. And I certainly need to acknowledge that, not negate how important that is to people who have struggled with insomnia, stayed up and watched the sun come up, and it creates anxiety. So he's mandated to me via court system If he doesn't stay abstinent, he's going to motion to revoke and do a 5-year sentence. So I asked him, how important is your sleep to you? Scale of 1 to 10. He said, it's a 9.
Mm-hmm.
I said, okay. I said, well, on a scale of 1 to 10, how important is it that you don't go to prison? He said a 10.
Mm-hmm.
I said, okay. So are you willing to work on not going to prison? It sounds like that's of higher value to you. Sometimes we have to just kind of weigh out pros and cons. We have to weigh out value.
Sure.
And essentially, client decides what's valuable. He may have told me that sleep was more important than going to prison. And so that's my question to them. Can you live with that then? Can you live with going to prison? All I can do is just educate them to become an informed consumer. If you choose this path, can you live with the results?
Mm-hmm. And I think that one of the challenges for young therapists is feeling as though they are responsible for making or helping a client change, to make that change, when in reality, that's not the case, is it?
Correct. No, in fact, boy, wouldn't we place ourselves in a position of arrogance if we knew what was best for everybody?
That's right. That's exactly right. And it's a recipe for burnout, isn't it? Really. I mean, when you think about that, is taking that kind of responsibility on and thinking that it's up to you all the time. It's just a recipe for burnout as well. So, well, talking about recipes, I always ask my guests about their recipes for success. And, we've just been talking here for a minute about clients who are coming in to see you for the first time, perhaps, and some of whom are motivated to change, some of whom aren't, but they're at that point A, and, our jobs is to try to get them to point B where they've fulfilled a goal, whatever goal that they've set for themselves. What's your recipe for success, Stacy, in helping a person with an addiction getting from that point A to point B?
Before we can get to point B, we must first determine what point B is.
All right.
For some clients, it might be abstinence and entering into long-term recovery.
Okay.
For others, it might be that they want to continue using, but maybe they want to go from IV drugs to regular drugs.
Okay.
Or maybe they want to go, which is progress in my book.
Mm-hmm.
If you go from something like intravenous heroin to smoking marijuana, to me, that is a tremendous progress.
Now, that might be a position that some people haven't heard before. I think a lot of people think, well, if you're going in for addictions counseling, then obviously the goal is always abstinence. But what I hear you saying is that that's not necessarily the case. That's
correct. There is more research supporting the idea of harm reduction.
Mm-hmm.
And I am a supporter of harm reduction.
Okay.
Now, there are some that are much more political in nature, which frankly I just don't have an opinion on one way or the other. Things
mm-hmm.
like needle programs or environments where people can use safely.
Mm-hmm.
I can't really weigh in on that because that doesn't really have anything to do with the work I do.
Okay.
But in terms of reducing the amount of substances that are used, switching substances to less harmful
mm-hmm.
Drugs, things like if you have a client that uses daily and their goal is to use only 2 times a week.
Uh-huh.
To me, I think it's a very positive starting place because regardless of whether it progresses to sole abstinence or even if a client continues to just persist with smoking marijuana versus IV drug use or they're only using 2 days a week, to me, it allows the client, we meet the client where they are, and it allows the client to actually identify and develop goals under the guise, gosh forbid, that they are the best person to run their own life,
uh-huh.
that they know what's best for them.
Sure.
So it does come from a perspective that's supported by our basic counseling tenets
mm-hmm. Mm-hmm.
of when we cannot help, we do no harm,
right.
that we meet them where they are, we foster autonomy. At the same time, I think it gives clients hope because there are measurable goals associated with that.
Mm-hmm.
I had a client recently that was able to stay clean 8 days before he started using again, and he was so pleased.
Mm-hmm.
And to me, we can utilize that. When we talk nowadays and he says, I think I might need to stop using again, I ask him, how did you do it in those 8 days? Why don't you do that?
Uh-huh. Right.
Already, it's built within them that there is ways that they can stay abstinent. They develop those. They achieve those. It's not going to be the way we all assume. And I think sometimes new counselors, or even counselors that have been in the field for a while, get wrapped around the axle because the moment the client says they want to continue to use or they just can't see a life without using, they begin to feel like, well, what's the point? Why am I going to sit in my office an hour a week with this person when they don't want to do anything?
Mm-hmm.
Maybe they do. We just have to find it. What is point B?
Mm-hmm.
And how do we take them there?
And what I'm really hearing, the kind of the underlying message here is that you trust your client, don't you, to do that?
Yes.
Yeah.
And I think they trust me to not promote my own ideals and values onto them.
That's so important. And so I guess so the thing you said is that the client really has to understand, and so does the therapist, what point B is, and part of that involves, I guess, the whole scaling thing. I guess that's part of it, but what you were talking about a little bit earlier, that woman had a lot of difficulty identifying what B looks like. What would my life be like without this substance? And how much time do you spend talking about that kind of stuff? What point B looks like, Stacy? Does that take time to do that with a client?
Absolutely. I think there's a lot of preparation involved and talking about fears. What are they afraid of might happen? Most of them have some kind of fear associated with being clean.
Mm-hmm.
I might never sleep again. How will I have fun? Everything I've ever done, I was under the influence.
Mm-hmm.
What will things look like? What will life look like? I have clients that have been drinking and using since they were 11 years old. They're in their 40s now.
Wow.
That would be scary.
That would be. Well, it's like what we were talking about before. It's like, you mean I have to say goodbye to my best friend? Or if they don't say goodbye to their best friend, something about my relationship with my friend is going to change, and I'm not sure what that's going to be like, and that's scary.
How will I cope with pain? That's another one. What happens if my mother dies, and what will I do? I don't think I can deal with that. I don't think I can be clean and sober if that happens.
Mm-hmm. Mm-hmm.
What if I don't get my kids back?
Right.
A lot of talk and preparation regarding what sober or clean might look like. Right. And most of my clients have been clean and sober before, if not for a week, at least.
Sure. Yeah. So what happens once they have that idea of what B looks like? Then what?
Then we start talking about measurable goals. How do we move towards that, whatever that might be? If it's reducing the amount of substances, if it's switching substances, if it's being abstinent. Of course, as an addiction counselor, it's important that, or for any counselor really, it's important that you remain knowledgeable about what type of level of care would be pertinent for each client based on whatever substances they're on, how long they're using them. There are substances that if they attempt to get off of them without medical treatment can be deadly.
Okay.
We certainly don't want to advocate for that.
Mm-hmm.
Alcohol and benzos are the deadly withdrawals. Oftentimes people think it's heroin, and it's not.
Okay.
Truth be told, when people detox off of heroin, they wish they were dead, but they're not going to die.
Yeah. Mm-hmm.
Yeah. So being knowledgeable about that, preparing your client, making sure that there are resources in terms of medical care or inpatient treatment, making sure that the level of care that you're offering them is congruent with the needs.
Mm-hmm. Mm-hmm.
Is seeing you once a week or twice a week, is that going to be sufficient? Mm-hmm. Or should they be stepped up to a higher level of care like intensive outpatient?
Right.
Do they need to go into detox? We begin there.
Mm-hmm.
And then we start creating plans. What is your plan of action? So say I've got a client who doesn't need detox, but they do want to come off of a substance or reduce the amount. It's things like setting up plans. What days are you going to be absent this week, and how will you deal with things on that day? What sort of support system can you bring around you? Just a lot of planning. A lot of education involved.
It sounds like it. It sounds like there's planning, there's problem solving. It's really just a lot of basic things that they might not necessarily know how to do themselves, but with the counselor's support, they're able to do and perhaps, hopefully, be successful doing it.
Yes.
So
have a place to check in.
What are some of the challenges, Stacy, in doing this kind of work? I mean, there might be a lot of people who are listening thinking that this sounds so great, I want to do it. But what should they know about some of the challenges in working with clients with addictions?
Well, you mentioned one earlier. The fact that this work can be heartbreaking. Mm-hmm. It really can. I think I spoke about my own personal challenges of just really having to separate my own values and my own feelings from the clients. Mm-hmm. Not judging them, really being that soft place to land. Mm-hmm. I think sometimes being content with small steps.
Okay.
One of the challenges I think we have is that because addiction is so impacting and so painful and oftentimes painful to watch, you have a client that's sitting in your office once a week and life is not getting better.
Right.
In fact, you can sometimes watch it progressively get worse. Mm-hmm. Having the ability to be patient with the small steps, things like maybe they only stayed sober 8 days, but they did it. Or maybe they got off the IV drugs and they've started smoking the drugs now, but they've done that.
Right.
Seeing those gradual steps, being that soft place to land, not judging them based on where they are. Of course, it challenges our own humanity. I've told most counselors that I work with and at UTSA that whatever areas of your life have not healed, it will come and sit in your office.
Mm-hmm. Yeah, isn't that the case? And as I was listening to you talk about this, I was thinking with people that you're working with addictions, they take perhaps 2 steps forwards and then 1 step back and then 2 steps forward. It's sort of like that process. And I imagine that as a counselor, that could be incredibly frustrating. And you have to be able to manage your own feelings, don't you, when you work with these clients?
You do. You have to manage your own feelings.
Yeah, and thinking, why can't you just make consistent progress? Why do you keep going back, and so I think that is part of this process. And I don't think this is just unique to people, clients with addictions. I think a lot of clients will bring up different feelings for therapists. And like you said, whatever your own issues are, those could be, a client could really press those buttons and make those issues come up for yourself. And so I think that there's a lot to be said about self-awareness as a therapist, huh?
And my experience is that when people present in my addiction course, I always ask on a private level, usually in terms of a paper that I have my students write, is what brought you to my class? And it's often unanimous. Most people that gravitate towards working with addiction have either had one themselves or they have family members with addiction. Mm-hmm. And that becomes a challenge because sometimes we don't know what hasn't healed until we sort of crash into it.
Right.
So their first client who has an addiction may remind them of their father, might remind them of their sister that overdosed, might remind them of even themselves. And that's painful.
Yeah.
It's difficult to be humble and willing enough to acknowledge our own counter-transference so that it doesn't impact our clients. But to be able to say to somebody, I'm really hurting right now. This person reminds me of my dad. This person reminds me of the anger I have towards my sibling. Mm-hmm. I don't know how effective I am right now. Everything inside me wants to make them see what they're doing to their loved ones, and then essentially we start working out our own problems through our clients.
Yes.
So,
right. And I guess this is where, where supervision comes into play, and talking to colleagues and when you're doing this, because this can be quite challenging work, I suppose.
yes.
Yeah. Well, Stacy, this last part of the interview, I talk about this as make a mental note, and it's something that you feel is important for the audience to make a mental note of in terms of improving their mental health or their relationship. Do you have any tips or suggestions for the audience about what they might do to enhance their wellness?
Sure. I believe that life is hard, and it's at best you can do everything right, but rain still falls on the just and the unjust. That being said, I believe that we are meant to walk this journey alone. We do need people. We're not supposed to be, I don't believe that we're meant to be autonomous and pull ourselves up by our bootstraps. Rather, through the connections and the people in our lives that we are strengthened and exhilarated. So my advice to anyone is make you surround yourself with those who sharpen you, lift you up, share your passion for life, and increase your zest. In summary, my belief is that relationships is what improves our mental wellness.
Yeah,
that is if we seek the healthy ones.
Yeah, I couldn't agree more. I was just about to say, it's all about relationships, isn't it?
It is.
Yeah. Well, Stacy, how can a potential client contact you if they're interested in setting up an appointment with you?
I would say the best way to reach me is either email or phone. I can be reached via email at Stacy@Speedlin@gmail.com. I'll spell that. SPEEDLIN@gmail.com. My cell phone number, which is 210-816-0393.
Okay, that's great. And I'll make sure and put that in the show notes as well, so if anybody wants to get it that way, they can. Well, Stacy, thanks so much for coming on to the podcast interview. This was truly informative. I learned a lot by talking to you, and I'm sure the listeners have too. So thanks so much for coming on today.
Thank you so much for having me.
Okay, it was great to have Stacy come on to the Make a Mental Note podcast today to share her perspectives on addictions counseling. And here's my mental notes takeaway for today. It's common for people with addictions to use substances to deal with pain, whether it's physical or emotional pain. And in this sense, substances serve a positive function. But with continued use, these substances can lead to harm. So the key is for people to replace these with a palatable alternative or change the way they use substances in order to reduce the potential for harm. Now here's my question for you. How is discontinuing the use of substances similar to breaking up with a girlfriend or a boyfriend for people with addictions? Well, even though people with addictions may understand that their relationships with substances are no good, they know that the relationship has to change in order to break the cycle of addiction. And people with addictions grieve the loss of their substances, similar to how people grieve the loss of romantic partners or people they were in close relationships with. And the fear is, what if I let this substance, go and I can't find something else? What am I going to replace it with? The prospect of never having the substance in their life again is daunting and scary and sad. Okay, if you would like the show notes for today's podcast episode, then please visit my website, chrisquarto.com. And if you like what you're hearing on these podcasts, then please consider Googling Make a Mental Note Podcast iTunes and write a short review. Thanks as always for listening, and have a great rest of the day.